Our next speaker is our very dynamic Dr. Kamal Kapur. He's going to showcase a wonderful case. So let's learn from him. On to you, Dr. Kamal.
Okay, thank you, Dr. Chitra. Thank you, AIOS. I feel honored to be on this platform. I'll show you an interesting case. This is a case of corneascleral perforation with iris incarceration, lens rupture, and a torn iris. This is a 5-year-old girl. She came from outside Delhi, and this is a 4-day-old injury. So, yeah, so I'll go on with the video. Now, this is how the case is in the operation theater. You will see there's a torn iris. The capsule is being torn here. There's an iris incarceration, and we proceed with the surgery. This is a traumatic case. This girl was hit by a brother with a TV remote. So she had a perforation. Luckily, there was no infection. So I used 2 different kinds of viscoelastic here. And I'm using a heel-on here just to push in the further iris which is coming here. And in this area, I'm putting in methyl cellulose because I'm not sure of what is the extent here. Is there a tear here? We did a UBM and we saw there was no tear, but I still wanted to be sure here. So I make sure I remove the iris incarceration very slowly, gradually. The caution is not to pull too hard, otherwise you could cause iridodialysis. We suture the wound after ensuring that the iris is totally out of the incarceration. Now I will rotate my microscope and go to the superior side. You notice now this area has come on the temporal side. Earlier I was sitting on the temporal side. Now we stain, and now I want to see how much of capsule is remaining, how much is the capsule torn. Now I use a blunt instrument to actually break the synechia, and I'm trying to actually lift and look behind the pupil to see how much is the extent of the tear. Is it from equator to equator? Has it crossed the equator? I'm not sure. So I do a very gradual and a gentle, I'm just doing a fast forward here so it looks a bit aggressive, but in the real slow motion, I had to compress this video to 4 minutes. So this is slightly fast motion. Now I'm actually pushing back the iris, and I found out that the capsule tear is complete tear. This is the straight line, and this is the another part of the capsule. So the capsule has got fibrosed and retracted here, and there's a capsule torn here. So now I will proceed to do my capsulorhexis. Again, I will use my innovative technique of the T-rexis. I will give a linear cut with a needle. Then I'll use a Vanas to create perpendicular cuts there, which gives me a better control of the flaps. This is a flocculent cataract. I have to make sure at all the times that the anterior chamber pressure is good. Now I have created a nick in between. Now I use microforceps to complete my rhexis. The trick here is to ensure to have as large rhexis as possible, because the other part of the rhexis is a fibrosed area there. Now I will complete the rhexis here, but I will get stuck up because there's a part of the iris which is stuck up with the synechia. I need to pull it out, otherwise I could not be finishing my capsulorhexis. But since this is a flocculent cataract, I don't need to do much. I just keep hydrating it with a cannula and make sure I dislodge it totally outside the eye. Now I use a Simcoe. I do not want to use an irrigation aspiration here because I'm still not sure of the capsular tags which may be there. It's a blind procedure. So once I've done everything, I go and put in a lens. Now I dial it again perpendicular to the axis, which I was presuming that this is my capsulorhexis. Now I go to do the single pass 4-throw technique as described by Dr. Amar Agarwal. I think this is a beautiful technique. It has transformed the way we handle iris. So we go ahead, we do the railroad technique. Now I've started making only 1 port. Earlier I was making 2 ports. I had a discussion with Dr. Amar. I use 1 port from where I go with the needle, and the other port I just use it to railroad. Now you do a 4-pass technique. Now in this particular case, I decided before I do that, I always put very small amount of pilocarpine before I do an iris repair. It gives me a very fair idea of what is the pupil size I would be looking at achieving. Now, once this is done, I will proceed to do another single pass 4-throw technique. And now having done the second one, I will proceed again to close the pupil to make it as round as possible. And now once this is done, I use the forceps borrowed from my retina colleagues, and this works excellent. Now this is the case beautifully done, and it has been operated, and the patient is very happy. And this is how the patient was post-op, and this is how the patient was pre-op. Thank you.
Thank you very much, Dr. Kamal. That was an amazing video. there was hardly much to ask, but I'm going to ask you 2 questions so that some more clarity comes about the things which we could look into. One is, what is the scientific basis of doing that inverted T-cut, which I do understand you're able to raise flaps on either side and do it. That. The second question is, when you have a rhexis extension and these younger individuals with a traumatic cataract, there is a, even though you think you have placed the lens in the bag, there could be the IOL which comes, the haptic which will come and sit in the sulcus. In that kind of a case, would it not make sense to do a posterior capsulorhexis if you could, and then both the two anterior capsule and the posterior leaflet would fuse and the IOL would be very stable? Like in pediatric cataracts nowadays posterior capsulorhexis is a very popular way of doing it. So your thoughts?
Okay, I think wonderful question, Dr. Chitra. As usual, you come out with these pearls of questions which actually split the case wide open and for people to understand. The T-rexes I have seen, at least in my hands, I am able to manage any kind of capsular complication. Dr. Maipal and Dr. Namrata were there in DOS again. I showed around, say, 8-9 videos of managing different kind of complications with the T-rexes. The reason why I do a T-rexes is I always have 2 chances. I make 2 flaps. If the first one starts going out of control, I can get the other one from the other side. In this particular case, I could see a fibrous linear line which was behind the pupil. So I had 2 lenses standby. One was a 3-piece. Now, God forbid, if I was not sure, if I could not see the other side of the capsule, then I would have definitely done a posterior capsulotomy and the 3-piece with the posterior capsule capture. But in this case, since I saw a fibrous, very good envelope, kind of a linear cut behind the iris on the opposite side, I was sure that I pushed the lens in, I lifted the iris to see that it is in the bag, and then from this side, I put it inside. So it's a great idea if I have no surety of capsular support on the interior side. A 3-piece lens or even doing a posterior capsulorhexis is the alternative. You're right. But in this particular case, it worked perfectly for me. There was one patch of straight linear line of capsule, which was white linear, and it was fibrous and it was tough, and there was no way it was going to give way on me. So I slipped the lens in like I slip it into an envelope, and the other piece I dialed in on the rhexis, which I completed with the T-rexis.
Dr. Vavikar, would you have anything to tell? Dr. Namrata is telling. Yes, Dr. Namrata.
I just wanted to put in some points. Of course, very nicely done, Kamal, and you you had an excellent result. But whenever you're breaking synechiae, you can break the synechiae and also then put intracameral adrenaline, because what happens is that once the synechiae are there, probably the adrenaline will not dilate the pupil, but once they are released, and if you put it and keep putting the HA drops also or tropicamide drops beforehand, because once the synechiae are released, then your drug works. Second thing is that you could have also put, nylon hooks to see what actually the extent, where the margins were torn and where it was not. So that kind of clears up the picture. And of course, your T cut is the hallmark of Dr. Kamal Kapur and copyrighted by him and excellently works very well. Rexes, I feel I would not make large and not that large in these cases, because you don't know what is the status of the PC and what is the status of the remaining anterior capsule margin. So you may have to put the lens in the sulcus depending upon what the situation it is. And of course, you use Simcoe very nicely, but I think bimanual would also help to do the same thing. Depends on who's comfortable with what.
Absolutely.
Dr. Vavikar, you have anything to add, or any others on the expert panel?
Excellent video, very well managed case.
You have to be louder, Dr. Vavikar.
Can't hear you, Dr. Vavikar.
Hello, can you hear me now?
Yes.
Slightly better.
Excellent video, very well managed. See, the thing about posterior capsule is that if you want to have a IOL capture in the posterior capsule, it has to be 5 millimeter and absolutely central, and it is not all that easy. It has got a lot of learning curve. So I think I would have managed it exactly the same way as Dr. Kamal has managed.
Anything else to be added, Ramurthy, Dr. Mahipal?
Just one point for the sake of any youngsters who are tuned in is that, having a torn capsule like this or doing a can opener is actually, there's lesser tendency for the rexis to run to the periphery or to wrap around and involve the posterior capsule, rather than having a single point of runoff. So whenever you are having a situation like that and you're not able to manage it, maybe creating multiple small punctures might help. Of course, this is not relevant to this case. And beautiful video and very well managed, Kamal. The only small point I want to make, because I paid a price for it in a few cases, is that, whenever you are railroading, make sure that you pass the straight needle through both the leaflets of the iris. If you pass the needle through, like, he managed it very well, but I had situations where I passed it through the iris and created a large tear of the iris. So passing the needle through the two flaps of the iris, keeping the needle just supporting it outside, might be a good idea and gives you a better outcome.
Thank you very much, Kamal. Needless to say, it was a great video.